And for similar papers regarding immunology we learned in our previous week. So our first MCQ, a 65-year-old woman is enrolled in a clinical trial to test a new medication for rheumatoid arthritis. The patient's condition can be purely controlled despite prolonged treatment with multiple disease-modifying anti-rheumatic drugs. The new medication CTLA-4 Ig fusion protein that prevents the CD28 from binding to CD80, 86 and antigen-presenting cells. A month after treatment begins, the patient reports a significant reduction in joint pain and stiffness. Laboratory results have a reduced level of C-reactive proteins and interleukin-2. Which of the following is the most likely underlying cause of this patient treatment response? Now, in this question, they are saying this is a patient rheumatoid arthritis, and they gave new medication that is CTLA4 Ig that prevents CD28 binding with the CD18. If you guys know, the CD28 and CD80 by T6 binding is a co-stimulatory signal or co-stimulatory signal. Signal for the activation of T cells. So after giving this drug, they find that there will be decrease in level of C-reactive protein and interleukin-2 that are inflammatory cytokines, and by that they are getting the response. Now we have to give what type of phenomena the CTLA is using. It will do complement inhibition, it will do immune complex clearance, negative selection, peripheral tolerance, and sensitization. Let me elaborate that thing to you guys. Actually, about which drug they are talking. They are talking about apacept, a disease-modifying anti-rheumatic that a fusion of CT and D4, and with the FC region of IgG. So its full name is CT and D4 IgG. Because it is a fusion of CTLA4 with the FC region of IgG. And what is it do then? It is a natural occurring immune checkpoint receptor that is upregulatory on the surface of active T cell. It acts as a brake for adaptive immune response by preventing the conversion of antigen-specific naive T cell into effector T cell. The main function, it is a checkpoint to convert the naive T cell into effector responsive T cells. The activation of cytotoxic T cell requires two co-stimulatory signals. I have a diagram, by this I will explain you. And if you guys know, the T cell activation needs two signals. The B cell also, T cell also, they need two signals for the activation. The first signal is between the TCR, the T cell receptor with MSC class 1. Okay. If it is a MSC class 1, so which T cell we are talking of? We are talking about CD8. Okay. And if you guys know about the rule of 8, and it is the first signal. The second signal is between the CD20 or 86 and CD28. When both the signals are getting by a T cell and antigen presenting cell, then the T cells become activate and they start the killing of bacteria. Understand? But when we are giving that drug abtacibcept, it is what it is doing. Already antigen presenting cell giving the MSC class 1 to the T cell receptor CD8, but for the activation it also needs second stimulation second signal between the CD86 and CD28. So what the distract will come and attach with CD20, CD80 or 86 or inhibit second signal. So what is going to happen? The antigen presenting cell is presenting the antigen to the cell and they are going to attach to the receptor, but they are not active because we block the second signal, and that is called energy. Energy means the T cell is containing the antigen, the T cell is going to attach with antigen presenting cell, but it not active, it don't become active and it become inactivated, it not give any response, disperse as a scared energy, and it is happening by some drugs or by abrupting the second signal. So the same phenomena we done, and that will be called peripheral tolerance. So our answer is peripheral tolerance. Whatever T cell that bind an antigen or APC that are now co-stimulated undergo energy a form of peripheral immune tolerance marked by a lack of T cell response to cytokine like an antigen stimulation, and it is called T cell inactivation. So that energy process is peripheral immune tolerance. Mean they are not more responding to cytokines like or antigens. Because CTLA4 binds to CD80 with a greater affinity than CD28, and administration of exogenous CTLA4 reduce the availability of the ligand necessary for T cell co-stimulation, which dramatically increases T cell energy in areas of active inflammation, so that we get the response by drugs. Because you know the rheumatoid arthritis is inflammation, that's it, we have to decrease the inflammation by decreasing the T cell activation. So we are doing by energy process. Don't forget that process. Now we are moving to the next question. Our next question is, a 19-year-old woman come to the office to discuss treatment option for seasonal sneezing, rhinorrhea, and nasal congestion. She had these symptoms for past few springs and summer, but is now willing to try anything to allow her to concentrate on her upcoming final exams. The patient had no significant medical history, take no medication, had no drug allergy. First of all, the woman is so young, 19 years is just like a student, like you guys. And secondly, it is common that students, when the exams are coming, they're having the stress, they also become ill, get a seasonal fever or allergies. This is normal. So vital signs are within normal limits, and physical examination reveals mild bilateral pain or blocking nasal turbinates with corpuscles clear mucus. Fluticasone and intranasal glucocorticoids is a prescribed, which are following the most likely mechanism of action of this drug. So, multi statements are just a story. In the normal, we have to just give the answer of this question. What is the question? Fluticasone is how going to do its mechanism action against the rhinorrhea. For that, first we have to study about the anti-inflammatory effect of glucocorticoid. They will bind with the glucocorticoid receptor present cytoplasm. By this receptor, they are getting NFKB that is going in a nucleus, and that is also going in there, modifying and doing. Again, I'm saying the glucocorticoid bind to cytoplasmic receptors and translocate to the nucleus where they inhibit the transcription of the genes. Inhibit the transcription of the genes that encode the inflammatory mediators and decrease the immune cell survival and propagation. That results in wide-ranging effect that suppress the immunostimulatory activity of all leukocyte cell lines, and that is following in this picture. First, there will be decrease the production of pro-inflammatory prostaglandin If you guys know, there are two types of cytokines or mediators. Pro-inflammatory, that is going to start inflammation, anti-inflammatory, they decrease the inflammation. So they first decrease the production of pro-inflammatory prostaglandin leukotriene to the inhibition of phospholipase A2. How it will be? They may inhibit the transcription of DNA, they will increase in annexin 1 that's going to inhibit phospholipase 2. If you guys enable phospholipase 2, then there will be decrease in arachidonic acid, decrease in prostaglandin, decrease in leukotrienes. So automatically they will be decreasing inflammation because these all are pro-inflammatory inflammation mediators. Understand? What going to second? Now they will increase the production of anti-inflammatory cytokines. What are the interleukin 10? They will increase the anti-inflammatory cytokines. So they will be decrease the inflammation. Also decrease the inflammatory cytokine that are interferon gamma, interleukin 1, tumor necrotic factor alpha. And they will, when these guys will be decreases, so automatically they will be decreasing leukocyte immigration. There will no leukocyte action, will be there, no locomotion is there. So one thing more, when the NFKB will come, they will also modify the DNA and they will decrease BCL2. When the BCL2 will be decreases, they will go to mitochondria, there will be release of cytochrome C, and that will cause the apoptosis of eosinophils. Understand? And they will increase apoptosis of eosinophils, T cells, monocytes, and perhaps by decreasing the BCL2 expression. And due to this decrease in inflammatory cytokines, there is an impaired macrophage activation and neutrophil immigration. These are all the mechanisms you should guys know about the steroids. Whenever anyone is taking steroid for as an anti-inflammatory effect, what they are doing, they will come and attach with their receptor that is present in cytoplasm, and that will go to the nucleus and they will inhibit the transcription of the genes and they will decrease the inflammatory cytokines, increase the anti-inflammatory cytokines that are interleukin 10, and also decrease BCL2 that will cause the apoptosis of eosinophils, T cells and monocytes, and also impair the macrophage activation and neutrophil immigration. So our right answer is apoptosis of tissue eosinophils by decreasing the activity of BCL2. If you guys remember the apoptosis topic in pathology. And if you guys are thinking about antagonism of leukotriene receptors, why it is not the answer? So because firstly whenever somebody looking the question, they will answer like leukotriene receptor will be antagonist. No guys. The mast cells are eosinophil release cysteine ions containing leukotrienes like C4, D4 and E4 that trigger the mucous secretion and edema. The cysteine leukotriene receptor antagonists are montelukast and cephalocaste. And cephalocaste. Montelukast, cephalocaste, these are drugs that will be inhibit the leukotriene receptors. And it is improve allergic rhinitis. It is also improve allergic rhinitis, but in this question they are asking about glucocorticoids. So we have to give the phenomena and also only give the correct answer that is giving an option, that is apoptosis of tissue eosinophils. So now we are moving to the next question. The next question is immunoglobulins of different classes have different structures. Some immunoglobulins have a long hinge region between the FAB and FC region, whereas others lack the hinge region as shown in the image below. Like this is an image, that is the hinge point, and some antibodies having the hinge point, somebody did not having the hinge point. So the question is that the hinge region provides moment flexibility to the FAB region. This is the most likely to affect which of following immunoglobulin properties. So guys, there is the options affinity to antigen, there is the antibody polymerization, avidity to antigen, effector cell interaction. Or there is one more question. Option A, effector cell specificity. First of all, there is a two terms, affinity and avidity. The affinity refers to the strength of a single interaction. This refers to single interaction between two molecules. Affinity is a single interaction between two molecules. The strength is the strength of single interaction between two molecules. But avidity is referred to the overall strength of multiple interactions over between multivalent molecules. Like in simple, you can also take the affinities just about one molecule, and avidity is made by the total molecules that going to attach with that substance. That is called avidity. So that affinity to antigen or avidity, there is the one diagram that will more good to explain. Whenever the hinge is present, there will be increase in avidity. Understand? Like hinge means they have more avidity, overall they have more strength. Overall strength of multiple interaction offered between multiple molecules more. So like IgG, IgD, IgA, that three having hinge points, but IgE and IgM having no hinge points. And secondly, there's a one more thing regarding that. If one immunoglobulin having the hinge, it will having increase in avidity, but it's also having increased susceptibility to proteases. Proteases of bacteria. So these bacteria, however, the long hinge region are more susceptible to destruction by bacteria proteases. Like IgA proteases that present in bacteria, they will kill their antigens. And if we talk about all the structures, the immunoglobulins are composed of a pair of heavy the light chains. The light chains have variable in constant region. Heavy chains have a variable regions and 3 or 4 constant regions depending on the immunoglobulin types. The constant region, you guys know, having the 1, 2, and 3 constant regions like that. That all of 3 constant regions are involving immunoglobulin productions. The immunoglobulin generally further divided into two functional pieces like FAB fragment, like they are having the FAB region and they are having the FC region. In the FAB region, there is an antigenic specific epitopes. They will specifically attach with antigens or epitopes, and the FC region is going to attach with complement. They are the important points. But in the avidity, if we talk about the affinity and the avidity, the maximum of the avidity belongs to the maximum avidity. Avidity means the sum of overall the interaction of the molecules is going to Ig. The immunoglobulin with the maximum avidity, this title is just go to IgM because you know the IgM is a pentavalent. It having the more sites than others to attach to the molecules, so automatically it having more interaction. But if you had to highest or maximum affinity, it's the IgM. IgG having maximum affinity with the molecule. Understand? Now we are moving to our next question. In that question, we are having that single statement, but we have to answer the two questions that will be going to be the same. The following will apply to next two items. The item in the set must be answered in sequential order. Once you click proceed to next, you are not able to add or change an answer. Understand? It automatically happens in UWorld. Like whenever this type of questions come, first you have to answer one question, and when you click on next, you will not come back to change your answer in that question only. Okay? We're having this treatment. The 52-year-old woman come to emergency department with the pain, redness affecting her left leg. The patient's symptom became to 2 days ago and have progressed to the point where she can't walk without experiencing severe pain. Physics examination, and what is going to start is that going to start 2 days ago. Physical examination shows a large erythematous area with a distinct margin over her left lung. The area feels hot and indurated and is consciously tender. She is admitted to hospital for severe left lung cellulitis and started on intravenous cefazolin. Several minutes after infusion is started, she experienced shortness of breath, diffuse itching, and dizziness. Her blood pressure is 64/38 and heart rate is 130 per minute. On examination, there is a diffuse erythematous skin rash and biliary wheezing in her on the lung auscultation. And the question is, which of the following is the most likely to be evaluated in this patient's serum as a result of medication reaction? What is going to happen? Like he having the cellulitis, and for the cellulitis, the doctors give intravenous cefazolin. Okay, and this cefazolin, several minutes after, within the minute infusion started, she experienced shortness of breath, diffuse itching, and dizziness. And her blood pressure also low, and heart rate is high. So this patient experiencing an anaphylactic reaction. If you guys know or read the book of hypersensitivity type 1 reaction, the reaction will be in the minutes. And also there will be bronchospasm, itching, and dizziness like that. So anaphylaxis is a systematic type 1 hypersensitivity reaction characterized by increased vascular permeability and multi-system edema, leading to the massive shifting of intravascular fluid to extravascular compartment. And this anaphylactic reaction is due to cefazolin. Cefazolin is cephalosporin. Okay. So before we are moving to other, I will let you know that I having one table of anaphylaxis. First the things triggers anaphylaxis. Immune mediated like medication, food, and incense strings. Non-immune mediated by the intravenous contrast, medication, mast cell activation syndrome. And for the clinical manifestation in cardiovascular, there will be vasodilation that will result in hypertension and tissue edema and tachycardia. Already that given the condition, they are having hypertension and tachycardia. Respiratory, there will be upper airway edema, hoarseness, and bronchospasm due to developed wheezing. There will be cutaneous rashes, pruritus, and flushing, and GIT having nausea, vomiting, and abdominal pain. And for the treatment, we are giving intramuscular epinephrine. What we are giving? We are giving intramuscular epinephrine. I also having one diagram here. If you guys see it, look it. There's an intracellular pathogen that we're going to proteasomes, and proteasome make the peptide fragment of that pathogen, and they will be go to the endoplasmic reticulum. And there was a presence of beta-2 microglobin. Beta-2 microglobin are going to attach with peptide fragments, and they are transporting with TAP proteins. Peptide fragments are going to transport by step proteins in the endoplasmic reticulum, and that will join with beta 2 microglobulins, and that will go, they will become vesica, and they will go to the surfaces and present as the MSG class 1 to CD8 T cells. This is the mechanism. So, according to our answer, if endoplasmic reticulum is infected or mutated the transporting molecule, what is going to happen? There will be, which thing will be impaired? There will be cytotoxic T cell activation, where MSC class 1 molecule will be affected because the endoplasmic reticulum transported granules, transported molecules are going to damage, impaired. So if this process is going to impaired, if this one is going to impair, then MSC1 will not going to present to CD8 cells. So our answer will be cytotoxic T cell activation by MSC class 1 molecules. Understand? In all the question, you have to just, by your own mind, you have to find the main statements, and then you have to answer that question. And mainly the main statements are present in the last. Now the question is, a 68-year-old man comes to the emergency department with a 2-day history of a fever, chills, and productive cough. His temperature is 38.9, blood pressure 108/52, pulse 102, and the respiration is 26. Crackers and bronchial bed sounds are heard over the right lower lung. There is dullness to percussion over the same area. Chest X-ray reveals right lower lobe consolidations and right sided pleural effusion. The patient is started on appropriate treatment, and diagnostic thoracentesis is performed that shows an uncompleted pneumonic effusion. Venous lion, sample of inflammatory exudate is experimentally introduced into a normal human tissue. Rapid neutrophil locomotion is observed, which of following component of exudate is most likely responsible for this absorbed effect. Guys, this all was just a story. In the last, they only want to ask that when a sterile sample of inflammatory exudate experimentally introduced into a normal human tissue, there will be neutrophil locomotion. So which of following component, which of following cytokine is responsible for this effect like neutrophil locomotion? You know, one is very easy. The C5a complement is a taxi of a neutrophil, but it is not an option. What would be the next second option? That could be the right. The leukotriene before. Because you guys know the neutrophils is leukocytes. And I have in table 1 there will leukotrienes before is responsible for this absorb effect. First, I want to explain this table to you guys like arachidonic acid metabolic pathway. They will membrane phospholipids that make arachidonic acid by the hypophospholipase A2. Further, they will convert to two pathways. The COX 1 and 2 will go with the prostaglandins, and lipoxygenase make 5-HPT80. Understand? And then with the help of 1,2 lipoxygenase, it will convert it into lipoxin A4. Before that will do decrease in leukocyte recruitment, anti-inflammatory, and also they will do leukotriene B4, that is responsible for chemotaxis of leukocyte or neutrophils, like that they mentioned NLC4, D4, A4. B4 for the chemotaxis, and other C4, D4, and the E4 are for vasodilation, for increase in vascular permeability, and bronchospasm. And if we talk about the prostaglandin, in thromboxane A2 are responsive for vasoconstriction platelet aggregation. They are pro-thrombotic. Thromboxane is a pro-thrombotic. And anti-inflammatory lipoxin A4 and AB4 and pro-inflammatory leukotriene B4, C4, D4 and E4. And there's a prostacyclin that are anti-thrombotic. They decrease the platelet aggregation and vasodilation. And if you talk about the prostaglandin D2 and A2, they will be responsible for the edema, formation of edema by increasing the vascular permeability and vasodilation. And according to this story, if you want to know about that, all the story that given the question is about the paraneuromic effusions. This about already mentioned, it is about the paraneuromic effusion that occur frequently in bacterial pneumonia as a result of exudative fluid accumulation within the pleural space. Infection and other forms of inflammatory tissues. Injury cause increase in vascular permeability, leading to the formation of protein-rich exudates that contain a variety of biological active substances. Under the influence of inflammatory stimuli, cell membrane phospholipids release arachidonic acid, a precursor to the acetylcholine inflammatories like prostaglandin, leukotriene, and lipoxin. The most potent chemotactic cytokine is dicotrine P4. And in contrast to cysteinyl containing glycostrine like C4, D4, and E4 cause bronchospasm and increase the bronchial mucus secretion, and they are important in asthma pathogenesis. If you're going to talk about the glycotrines. And listen, now we'll move to your next question. But don't forget, this table is so important. Okay, guys? A 28-year-old woman traveled to bed to bring her healthy 60-year-old girl to the office to her first well baby checkup. An infant was born full term with a birth weight of 4.2 kg and a length of 5.1 centimeter. 51. She was discharged from the nursery with no concern. Physical examination normal. The infant's blood type is A negative, whereas the mother is a B negative. The high circulating level of anti-A antibody are found to be mother's blood. Hemolysis is not occurring in the infant because of the maternal antibody is most likely which class. So it is an MCQ about the immunoglobulins. Like they are asking about. Basically, it is question about hemolytic disease of fetus and newborn that is caused by the maternal anti-fetal erythrocyte IgG antibody. We can cross the placenta. If you that automatically that thing you guys know, the IgG cross the placenta and produce a type 2 antibody-mediated hypersensitivity response. With normal maternal blood types, A would be hemolysis does not occur because the maternal antibody anti or anti-B IgM type which can't cross the placenta. However, mother with a blood O also produce IgG antibody which can cause a hemolysis in the fetus. In ABO blood incompatibility, the blood group of maternal blood group A and B did not cause a hemolysis because if one woman having blood group A, he having antigens A and the antibodies B. If anyone having blood group B, she having antigens B and antibody A. But normally, the anti-B and anti-Ig immunoglobulins. With these antibodies, they have IgM. And you know, IgM did not cross placenta. So A, B did not do hemolysis. But if anybody having O blood group, they will have no antigens, but they are having the maternal same antibody anti-A and anti-B and the combination of IgM and IgG. Now that IgG will go across the placenta and can cause, by crossing placenta can cause hemolysis. So if anybody having O blood group, they are having the risk for hemolytic disease. Her baby having the risk for hemolytic disease, fetus and newborn. So why, due to which class of antibodies the hemolysis is not occurring? Due to IgM. The right answer is IgM. IgM is right answer. IgM is pentavalent, having increased in avidity. Now we are moving to our next question. Our next question is 35-year-old woman come to the office due to fever, headache, swellness, itches, and assault for the last 4 days. Physical examination showed mild pharyngeal asthma and nasal conditions. A rapid influenza antigen test is positive. Patient condition improves over the next several days despite receiving only symptomatic treatment. In response to influenza virus, infected respiratory epithelial cells begin secreting increased quantities of interferon. The specific interferon secreted by these cells will most likely cause visual following changes. That dimensions, the interferon is secreted by respiratory epithelial cells, and respiratory epithelial cells release interferon alpha and beta. So you have to answer these specific interferons secreted by these cells will most likely cause which of following changes. They will decrease the protein synthesis by infected cells. They will not do apoptosis. They will not increase MSC2 expression. They will not increase intracellular killing by macrophages. But it was also done by interferons. Why it is not right answer? Because the increase in intracellular killing by macrophages are stimulated by interferon gamma. And interferon gamma is released by T helper cell. T helper cell 1 cells release interferon gamma, and that is going to increase the killing macrophages. But it is not right answer because they ask about the interferon that relates from respiratory epithelial cells. I also want having diagram the antiviral actions of interferons. The viral RNA and the proteins will rapidly transmit to the near neighboring cells. But what will happen? You know, the interferon interfere with RNA DNA of the viruses, so they will interfere, and interferon bind to the neighboring cells and inhibit the production of proteins. So you know, guys, for the growth and the production and replication of a virus, they need the proteins. When there will be antiviral protein degraded, RNA hard protein synthesis, and there will be destruction of virus by the interferons. What interferon doing? Interferon will interfere with RNA or DNA and decrease the synthesis of proteins. So if there will no protein, there will not the formation of new cells, and it will enable for the viruses to replicate or reproduce. And we already know, and I already described you that the interferon gamma is a type 2 interferon produced mainly by T cells and natural killer cells, and it promotes that T helper and differentiation. We were talking about that was done, but now we're talking about the interferon. Gamma is also an important topic that is released by T cells also by in these way natural killer cells and T cells, and it promotes the differentiation of T alpha cell 1 and increase the expression of MSC class 2 on antigen presentation and improves the intracellular killing of macrophages. So now we are moving to our next question. Next question is about 8-year-old. Boy that is brought to the office due to fever and sore throat for the past several days. He has no runny nose or cough. The temperature is 38.4. Physical examination shows erythematous pharyngeal mucosa with enlarged tonsils covered by exudate tonsils mean lymph node enlarged, and they are enlarged and tender and tears the white lymph nodes as representatives. Image of one of the enlarged nodes is shown below. The structure indicated by the arrows are increase in size and number. The predominant cell type within these regions are most likely undergoing which of following processes. Kind. Just remember how the starting page of immunology was the structure of lymph nodes. And if you focus on that picture only, and remember that in lymph node there was follicles. And in follicles there are germinal sensors. And these are large germinal centers. They must be seen in secondary follicle due to B cell activation. You guys know in follicle there is B cell activation. Just like that, understand? And then if you know there's a whitish particles that are the tingle body with the macrophages, and they are having dominant B cells. Basically this image giving a diagnosis a lymph node with follicular hyperplasia, because the enlarged parts are follicle pie sugar. It's not there. Cortex, paracortex, follicle, and follicle having two parts, and one is the germinal center in which there is the active sites for the production of B cells. So they are saying the question that the predominant cell type within these regions most likely undergo which of following process. What is the predominant cell type? B cell. And B cell is doing which thing here? They will do isotype switching. They will do isotype switching here. Understand? This is a thing to remember. Later I will give you a chart for the B lymphocyte development. First, if you guys know, these start from bone marrow. And in bone marrow, it is hematopoietic stem cell, hematopoietic stem cell convert into pro B cell, and that pro B cell is converted into pre B cell, and that pre B cell converting into immature B cell, and that immature B cell is going toward spleen. And in spleen, that immature B cell converts into transitional B cell. And this transitional B cell converts into mature B cell inside the spleen. Now the mature B cell is going to lymph, going to lymphoid tissue or lymph tissues, and that mature B cell is now activated B cell. And that activated B cells are going to convert into memory B cell, and will convert into plasma cells. And that plasma cells are activated cells, they secrete antibodies. And these antibodies are also going to switching process, and that switching process are happening in germinal, that is happening in germinal center of lymph node. Understand? And now I will want to show you some switching. For example, how different, basically they will be releasing IgM and IgD, the B cells. How they will be switched? If the B cell is going to expose different cytokines, the first I am going to mention, if it is going to expose to interferon gamma, or it is going to expose interleukin 4, interleukin 13, or it is going to expose to interleukin 5 or tumor growth factor beta. So what is going to happen? If any B cell is going to expose with the interferon gamma, then they will be switching to IgG. If there are exposure of B cell to interferon 4, interleukin 4, interleukin 13, then it will be going to switch with IgE. If there is exposure of B cell to interleukin 5, tumor growth factor beta, then there will be class switching of immunoglobulins antibody into IgA. And this is just a summary of all the things. Now to our question, which of the following is most likely to be elevated in the patient's serum as a result of a medication reaction? Due to anaphylactic reaction, which of following will be increased in blood serum of patient? So alkaline phosphatide, calcitonin, collagenase, myoperoxidase, tryptase. It's so hard. So guess, because you guys normally know in an anaphylactic reaction, there will be increase in histamine. But in anaphylaxis result from the wide spread of mast cells and basophil degranulation. You guys know? Mast cell and basophils degranulation. These will result into tryptase and histamine. Whenever there is an anaphylactic reaction, there will be degranulation of mast cells and basophils that will be result in increase in serum, elevating the serum values of tryptase and histamine. Tryptase is an enzyme that is relatively specific to mast cells, and elevated serum levels of tryptase are often used to support a clinical diagnosis of anaphylaxis after the patient has been stabilized. Now we have moved to our next question of a same treatment. This patient anaphylactic reaction is determined to be mediated by antigen-specific IgE antibodies attached to high-affinity receptors on the surface of mast cells and the basophils. Which of following mechanism is most likely to trigger vegetative substance released by these cells? Now we have to tell about the mechanism. First we are saying which serum level is elevated, tryptase and histamine, but now we have to tell how the vegetative substances are released by these cells. What are the mechanism? It's an antibody receptor, antibody and receptor dissociation, receptor aggregation, detachment or internalization. If you guys remember the page of immunology where in the first year where the hypersensitivity reaction diagram is mentioned, they mentioned that having the receptor aggregation. What happened? In high affinity Ig receptor activation, the multivalent Ig A multiple antigen will going to bind with the IgE receptors of the mast cells or basophils. What is going to happen? There will be secretory granules already present in the mast cells. Aggregation of IgE receptors. Understand? So answer, receptor aggregation is a mechanism that is likely to trigger vasoactive substance released by basophils or mast cells. Now we are moving to our next question. Our next question is, a 5-year-old girl did brought to the office with the evaluation of persistent cough. The patient has productive cough daily for the past month. History includes recurrent episodes of otitis media despite bilateral ear tube replacement and numerous lower respiratory tract infection occasionally ulcerative skin lesions. The laboratory evaluation shows normal levels of total B and T cells and serum immunoglobulins. Genetic testing reveals a mutation in the TAP1 gene, which encodes a protein involved in transport of cytosolic molecules in the endoplasmic reticulum. Which of the following process is most likely to be impaired by this mutation? In this one question, they are saying in that patient there is mutation of TAP gene, and TAP gene is responsible for the transportation of molecules in endoplasmic reticulum. If you guys remember, in the immunology, you learn about MSC class 1 S2, and there was 1% how the antigen on presentation going to encode and make the presenting cells. The MSC1 is going to make endogenous antigen, and they are making by the TAP proteins that is going to endoplasmic reticulum, and there will be MSC. One will activate and go on the cell surface.